So, good evening, everybody. I am here again, myself, Dr. Archit Agarwal. Uh, we had discontinued session in morning due to net problem. I practice in QRG Central Hospital and KDC Skin Clinic. I am going to talk about differential diagnosis of Tinea infection. And coming to introduction, Tinea infections are very common infections. They are most common type of skin infection seen in 25% of worldwide population. In our skin OPDs also, we see 50 to 60% OPD patients being suffering from Tinea infections or skin fungal infections. They are not life-threatening infections, but might cause severe morbidity to the patient in form of itching or nuisance. And it also affects hair, nail other than the skin, and it is caused by organism or fungi known as dermatophytes. So we know that the diagnosis of this fungal infection or tinea is made by clinical observation only, but sometimes it is very difficult to tell by clinically that whether this is tinea only or it is some mimicker, like Tinea corporis or the fungal infection on the body can mimic with eczema, or Tinea capitis, fungal infection of the scalp might mimic with alopecia areata. Onychomycosis, fungal infection of nail, can be confused with nail dystrophy due to trauma. So I will discuss about differential diagnosis of each of these conditions one by one, starting with Tinea corporis. So Tinea corporis, it presents with annular, meaning circular rash. It might be erythematous, and there is scaling at the periphery. It is polycyclic, like multiple cycles or smaller rings are connecting at the periphery, and there is central sparing or clearing of the skin. So this is the classical description of the rash occurring in the Tinea corporis patient. So red, annular, polycyclic margin, scaly, pruritic patch with central clearing and active border. And it is also called as ringworm, as we know. So coming to differential diagnosis of this condition, we have annular psoriasis, atopic dermatitis, erythema multiforme, fixed drug eruption, granuloma annulare, lupus erythematosus, nummular eczema, pityriasis rosea, and seborrheic dermatitis. So this is the case of annular psoriasis, not very common. It has silvery scales, as we can see, and the patient might also present with some family history of psoriasis and other features of psoriasis like psoriatic patches on other body parts and pitting of the nail. Coming to the next condition, atopic dermatitis. Atopic dermatitis presents with vesicles or blisters on the affected area, pruritic patch, and atopic dermatitis mostly involves the younger age group like children, though it might also involve the adults or later ages. But with chronicity or increase in duration of the disease, these vesicles rise up and the lesions might become hard or scaly, and that is called as lichenified lesions. So they don't have any active borders and they look like more like eczema or boiling out or oozy skin. This is a case of erythema multiforme. They present with targetoid lesions or bull's-eye lesions. Erythema multiforme is an allergic condition, and it might occur due to virus infection or some drugs, commonly NSAID drugs, painkillers, antibiotics, then anti-epileptic drugs. It can occur anywhere on the body, but commonly presents over the palms and soles, and they uncommonly present with scales, and they are generally, they have acute onset, sudden onset after the intake of drug within 1 to 2 days, and sometimes they might be associated with oral lesions also, like ulceration. So this is the case of fixed drug eruption. fixed drug eruptions have dusky erythema, redness to blackness in the center, and generally one or two or very few lesions will be there on the body. Sometimes mucosal surfaces might be involved, like penis or genital area or mouth part. And we know that fixed drug eruption is caused by the drugs like NSAIDs, painkillers, sulfa antibiotics, and these are non-scaly lesions. Generally, pruritus is not there, burning sensation might be associated. This is a case of mala rash or butterfly rash on the face, photoexposed areas in systemic lupus erythematosus. Then this is a case of numbler eczema or point-shaped eczema, commonly occurring over the extremities, and they do not have much of scaling, and again they have oozy or boiled out appearance, and these are extremely pruritic lesions. Herald patch or mother patch, we know that pityriasis rosea is an allergic phenomena which occurs after viral infections or might occur after seasonal changes. The initial patch which appears is a mother patch or a bigger patch, also called as herald patch, which is followed after few days by similar but smaller daughter patches all over the body. And as we see, the scaling is more over the inner side of the patch, not on the outer side of the patch. So this is called circinate scales. The circinate scales, and pruritus is not that much as in tinea, and it commonly involves the neck, the trunk, that is chest, back, and the proximal extremities. And though it looks much like tinea, antifungals don't have any role here. So this is a case of seborrheic dermatitis, also called as cradle cap in younger babies, and it presents with greasy scale on an erythematous base. And though we know that seborrheic dermatitis has clinically it is mainly distributed over the scalp, over the eyebrows, nasolabial fold, then over the chest, and posterior auricular fossa, behind the ears also. So annular lesions is not seen in seborrheic dermatitis. So these were the differential diagnosis for Tinea corporis, mainly fixed drug eruption, erythema multiforme, pityriasis rosea, seborrheic dermatitis. Then coming to Tinea cruris. The Tinea cruris means the tinea infection affecting the body fold, like intramammary fold, in the armpit region, in groin areas. So this is a case of partially treated Tinea cruris, as we see this little hyperpigmentation over there, and we can see that erythematous area or red area over this area, and there is scaling at the border. So this is a case of Tinea cruris, and interestingly, the Tinea cruris, there is sparing of the scrotum area or the central area. There might be sparing, but generally we see the sparing. But this is not the case in candidiasis. Candidiasis is also a superficial fungal infection, and but it presents with erythematous rash over the groin area, and there is satellite lesions. We'll see later in this slide. But scrotum might be involved in the candidiasis, which is not the case in maximum number of Tinea cruris patients. And when we come to the differential diagnosis of Tinea cruris, we have candidial intertrigo, as I was talking about. We have an bacterial infection called as erythrasma. Then we have invert psoriasis, and we have seborrheic dermatitis. So this is a case of candidial intertrigo. We can see the satellite lesions which is away from the main rash, and the satellite lesions is quite characteristic of candidiasis. And here we see the involvement of the central area also, which is not seen generally in the Tinea cruris. So this is the case of erythrasma caused by Corynebacterium minutissimum, and this might appear as reddish to brownish patch, but they are asymptomatic in areas which is more affected by the sweating. And on Wood's lamp examination, they give a reddish fluorescence, and that is due to porphyrin secreted by these bacteria. And we see no active border. There is no central clearing here. So this is a differential diagnosis for Tinea cruris. This is a case of inward psoriasis. We know that psoriasis generally involves the extensors like back of the elbows, the front of the knees, the scalp, lower back. But when the psoriasis affects the body fold, like the inframammary fold or the armpit region, then it is called as inward psoriasis. So this might cause confusion with Tinea cruris, but there might be other symptoms of psoriasis also, like nail pitting, joint involvement of other body areas like scalp and other skin, and there is a shiny scale over this red patches here, which is characteristically seen in psoriasis. And if we scrape this lesion, we see pinpoint bleeding, that is called as Auspitz sign, which is also seen in psoriasis. But these lesions due to sweating might become macerated, in contrast to classical cases of psoriasis where the scales are very dry. So this is a case of seborrheic dermatitis. We have discussed earlier that seborrheic dermatitis appear as a greasy yellow rash over an erythematous base, over a red base, most commonly over the scalp, over the nasolabial fold and retroauricular area. But it might also involve the chest. It can also involve the genital area. But we can see that greasy or yellowish tinge over the rash is there, and it might be associated with similar lesion over the other seborrheic areas also. So greasy scale on erythematous base is characteristic of seborrheic dermatitis. Here also we don't see any annular lesion. There is no central clearing here. Only dense erythema is seen on the chest. So this is a differential diagnosis for Tinea cruris. So these were my differential diagnosis for Tinea cruris, like seborrheic dermatitis we have discussed, then inward psoriasis we have discussed, and we have discussed erythrasma, and we have discussed candidial intertricho. Then next is Tinea pedis. Tinea pedis is the fungal infection of the foot. So initially the fungal infection might look like rings, and if it involves interdigital web spaces, there is maceration of the maceration or wetty interdigital spaces. But once it becomes chronic, or it might present with scaling, but which is presented in other conditions also. But in Tinea pedis, generally the patient is quite asymptomatic. Even if the pruritus is there, it is minimal, and on the top of it, both the soles might be involved, but there is asymmetrical distribution. Like if one sole is involved, it will be involved in more area, and other sole will be involved in smaller area. There won't be symmetrical appearance of the rash on both the soles, or otherwise it might involve only one feet. So it typically involves the skin between the folds and can spread to the sides of the soles also, and dorsum or the front part of the foot also. So there might be redness, there might be maceration between the toes, as I told, and there might be vesicles. So classically also we divide the Tinea pedis into 4 categories. It is scaly type, then there is interdigital web space type, there is ulcerative type where we see ulceration, and there is vesicular type where we see vesicles, or where we see blisters. So my differential diagnosis for Tinea pedis is contact dermatitis, then dyshydrotic eczema, psoriasis, and juvenile plantar dermatitis. We'll discuss them one by one. So this is a case of contact dermatitis, as I was talking, we can see very symmetrical. It is almost same or mirror image in both the feet. So that won't be seen in tinea. Tinea will involve either only one feet or it will involve one feet more than the other feet. And so these patients with contact dermatitis generally will have a pattern that might mimic the areas of contact with the footwear or otherwise. And generally the interdigital skin won't be involved. So this is a case of dyshydrotic eczema. There will be increased sweating over the sole, and areas of contact like the greater toe and the heel areas are generally commonly affected there. And there might be small blisters over the sole, and that is called as tapioca pudding vesicle. And it can also involve the hands also, where we see both the palms and soles being affected by this dyshydrotic eczema. So this is also very common rash. It is commonly seen in smaller children or younger children, and it presents with asymptomatic scaling over the front part of the foot, like involving the great toe, other fingers, and the ball of the toe, or the front part of the sole is involved, and it is seasonal. They subside by themselves within a short span of time. And the interdigital spaces is not involved in juvenile plantar dermatitis. Coming to plantar psoriasis, they'll have feature of the classical psoriasis. There might be scaling or split sign, as we have discussed earlier, and or it might become pustular. We see the collection of pus inside the rash and blisters also. So it might either become pustular psoriasis or it might be scaly. So other features of psoriasis suggestive are the scaly plaques over the other body parts like palm soles, over the scalp, over the extensors. There might be a family history of psoriasis. There might be nail pitting, and generally that silver classical mica-like scale is seen in psoriasis if it is scaly psoriasis. So those were the differential diagnosis for Tinea pedis. Now coming to Tinea capitis, or the fungal infection of the scalp. So normally either it is inflammatory or non-inflammatory. So if inflammatory is there, it will present with either collection that is called as pedis, or pus or boggy swelling that is called as chirion. And if it is non-inflammatory, either it will present with alopecia or bald patches. It might present with gray patches, or it might present with fragility of the hair leading to black dots. So depending upon this, we can classify this into inflammatory and non-inflammatory. And it is very helpful to know that Tinea pedis is commonly seen in younger children, like preschool and early school going children, and it is uncommon in adults or adolescents. So as I was talking, might present with alopecia, scaling. If it presents with scaling, it is called gray patch variety. If it is with fragility, we see patch of alopecia with black dots. So that is called as black dot variety of Tinea capitis. And if it presents with pus-filled lesions on the scalp, that is called as chirion. Or if it presents with collections, that is fungal colonies, cup-like collections, that is called as pedis. And there might be tenderness in pus-filled chirion. Otherwise also pruritus might be there. So because this is infection, the draining lymph node might be enlarged. Like in this case, suboccipital and cervical area lymph node might be enlarged. And hairs are very easily pluckable in this Tinea capitis, and it is not painful to pluck the hairs. which is also a very suggestive sign of Tinea capitis. So coming to my differential diagnosis, I have alopecia areata, atopic dermatitis, scalp bacterial infections, psoriasis, seborrheic dermatitis, and trichotillomania. So this is alopecia areata, multiple or single patches of baldness, and we can see black dots or exclamation hairs. Exclamation hairs is comma-like hairs, which is thicker over the periphery and thin as they come and meet the skin. So that is classically seen in alopecia areata. There is no skin surface changes or scaling as it is seen in Tinea capitis. And Tinea, this alopecia areata can occur in any age. It might occur in children, it might occur in adolescents or adults. And there is hardly any inflammation or any symptoms in alopecia areata except for the cosmetic disfigurement. So this is extensive scaling seen in atopic dermatitis. Though this type of scaling is uncommonly seen in clinical practice, other signs of atopic dermatitis like scaling on the other body parts, erythema, intense itching, or signs of atopy or history of atopy like bronchial asthma or rhinitis might be there. And scaling is there, but there is no annular rash and there is no alopecia here. Scalp psoriasis presents over localized area. They present with rash, which is classically seen in other psoriasis also. Mica-like thick scales with underlying erythema. If you scrape the scales, you see pinpoint bleeding. That is called as phosphate sign. So this is also a differential diagnosis for Tinea capitis. And we can always see signs of psoriasis in other body parts, like similar rash on the other body part, or family history, or joint involvement, or nail pitting. So this is seborrheic dermatitis, as we have discussed earlier. Greasy scales on red border, commonly seen in children, called as cradle cap. And we don't see the rash as we see in Tinea capitis, but still it is a differential diagnosis for Tinea capitis. And we know that it typically involves the seborrheic areas like scalp, eyebrows, eyelashes, the nasolabial fold, and the retroauricular areas. And this is a case of trichotillomania. Trichotillomania is alopecia or baldness occurring due to pulling of the hair by the patient. Either conscious or unconscious pulling of the hair by the patient might lead to trauma to the hair. And we see these patients, they have unequal hair. The length of the various hair, some will be larger hair, some will be smaller hair, and generally it is within the reach of the dominant hand. The area which is plugged by the patient is within the reach of the dominant hand, and they might also involve the loss of the eyebrows or eyelashes. The patient may or might not admit about plucking of the hair. But if we see very closely, or we see under the microscope or dermoscope, we see the trauma to the hair. The broken hair or broomstick hair can be seen in trichotillomania, along with variable length of the hair. So these are the common features: Tinea corporis, ringworm on the body, circular rashes; Tinea cruris over the groin areas; Tinea manum, diffuse scaling of the palms, which can be confused with psoriasis or contact dermatitis; Tinea pedis, either fissuring or maceration of the interdigital or web spaces; Tinea angum, or the fungal infection of the nail, is generally presents with discoloration, whitish discoloration of the distal or proximal nail part, and with the subungual scaling below the nail plate, there will be scaling and there will be lifting of the distal part, nail due to the collection of the keratin or the collection of the scales under the nail plate. So therapy only if localized body areas is involved. Topical antimycotic agents or antimicrobial agents like azoles or terbinafine is effective. If multiple body parts is involved or extensive service involvement is there, generally systemic antifungal therapy is there, along with the topical antifungal therapy. And we should always convince our patients about good hygiene tips, and that goes well along with uh, treatment with drugs, like maintaining hygiene, laundering the clothes, washing the clothes separately, avoiding tight clothes, using different towels, and avoiding contact with other family members. Um, and completing the course of treatment is very important. Otherwise, there is a good recurrence of fungal infection in the treated patient. And treatment of the patient contacts or house members having the same infection is also very important. So there is very much issue of using steroids, either oral steroids or injectable or topical steroids, either to give very fast cure or very fast relief to the patient, but this proves to be counterproductive for the patient, as this will result into resistance of the fungi. It will require longer treatment with antifungal drugs. Multiple drugs might be required in the patient. The patient will become non-compliant with the treatment, and this increases the burden of the cost of the therapy on the patient. And so we should never use steroids in case of tinea infections and or dermatophytic infection. We can use newer salts or newer azoles which have anti-inflammatory property if the patient complains of excessive itching. Otherwise, there is combinations of antipruritic agents like pramoxine with newer antifungals that can be used. So thank you everybody. I apologize for the morning trouble with the internet, and I am leaving my email address and my contact details. Any doubt arises, please feel free to contact me. Thank you.